In this lecture, we'll be talking about central nervous system diseases of white matter, which we'll divide into demyelinating and dysmyelinating disorders. Of course, it's always helpful from a big picture to contrast that with peripheral nervous system demyelinating disorders like Guillain-Barré syndrome or Charcot-Marie tooth. And so remember, of course, anatomically there you'd want to think of Schwann cells with the peripheral nervous system and oligodendrocytes being damaged in the central nervous system. And so we're up to the subcortical area in our trip through the nervous system. And so this time on white matter, next time we'll go over basal ganglia diseases. So when we use the term demyelinating, we mean that the myelin was formed normally and then was damaged. So multiple sclerosis, neuritis myeloptica, and ADEM, acute disseminated encephalomyelitis, would all be examples there of a patient who has normal myelin and then something happens and it's damaged. In dysmyelinating disorders, we have some biochemical defect, and so the myelin is never formed normally. So, with regards to multiple sclerosis, we have immune dysfunction which leads to damage to myelin. And so a lot of things need to come together here for multiple sclerosis. There are very complex genetic factors, which I don't think you need to know in detail, but is certainly very relevant. This in combination with immune dysfunction and environmental factors. So a lot of the risk of multiple sclerosis is determined by where someone grows up between the ages of 5 and 15. So basically the further away from the equator, the higher the risk. Lots of other things like vitamin D, smoking, these would all be environmental factors. So multiple sclerosis, of course, you'd want to think of as something that comes on in younger individuals around the age of 30, late 20s. Much more common in women, but men, remember, are more likely to get the primary progressive form. So the more common form is the relapsing remitting, but men may have this just gradual progression. And so the typical form is attacks or relapses. So let's just go through the areas of the nervous system most commonly involved. The optic nerve is myelinated by oligodendrocytes. And so optic neuritis is a very common presentation of MS. Recall that patients will have a central scotoma with this. And if you do an MRI scan, you can actually see enhancement of the optic nerve. And we've already been over in optic neuritis, the patient will complain of visual loss, but the demyelination is posterior back here. So when you look in the eye, you really don't see anything abnormal acutely. And we've already been over the afferent pupillary defect as the objective finding that you'll see in optic neuritis or any other optic neuropathy. So the classic pathway involved in the brainstem is the medial longitudinal fasciculus, which we can see right here. And recall that this pathway is important for coordinating horizontal eye movements. So weakness there will give a patient, or a lesion there will give a patient weakness of the ipsilateral medial rectus. And so when they look to the opposite side, that eye doesn't move along, and so the patient will complain of double vision. And that is known as an internuclear ophthalmoplegia. But lots of areas of the brainstem can be involved. So again, here's a patient with a left MLF lesion, so the patient looks to the right, and this eye doesn't cooperate. And remember, you normally, in an INO, see a little nystagmus in the normal eye, and that's just the brain's attempt to bring the images together. So vestibular pathways are often involved, so patients may have vertigo, dysarthria, dysphagia, like if we have demyelination of the corticobulbar tract. Remember, any brainstem lesion, you get crossed findings, ipsilateral cranial nerve, contralateral motor sensory, and if we have demyelination of the trigeminal sensory fibers when they enter the pons, patients may have episodes of facial pain. So we'd always want to consider multiple sclerosis in a young person presenting with episodes of facial pain. Now, upper motor neuron pathways are involved most commonly in the spinal cord, and so when that happens, it's known as transverse myelitis. So again, young people, that present over a short period of time with a rapidly progressive, usually paraplegia, sensory loss below the level of the lesion, and urinary incontinence. Often at the level of the lesion, there's a tight band sensation. That kind of helps you to localize it. Cerebellar pathways are often involved, so you get ataxia, nystagmus, and again, the middle-aged men, 40s, early 50s, have primary progressive multiple sclerosis, a lot different than relapsing remitting. So anything that involves widespread demyelination, especially involving the spinal cord, we commonly get incontinence and sexual dysfunction. Both of these are very, very common in patients with MS. So fatigue is common in MS, but this is totally different than myasthenia gravis. In myasthenia gravis, you get objective weakness that comes out with repeated testing. In multiple sclerosis, the issue is that in heat, the neurons conduct more slowly. And so if you have a demyelinating disorder, then you really bring out underlying symptoms. So this is known as the Uthoff phenomenon. And so patients that I've seen with this, maybe they had an episode of optic neuritis, and they got a lot better, as most patients do. But when patients go out into the heat, the visual loss in that eye that had the previous episode of optic neuritis may come out again. Okay, and that just reflects heat kind of bringing out the symptoms. So again, the common form of MS is you have an attack, optic neuritis, back to normal. Maybe here's transverse myelitis, back to normal. But the more episodes you have, the less likely the patients will come back to their baseline. Okay, so over time, 50 to 70% of patients merge into this secondary progressive form, where they just have this appearance of gradually getting worse. That's what we're trying to prevent with our therapy. So when we do an MRI scan, we see lots of demyelinating lesions, and classically these line up along the ventricles. Okay, we call these Dawson's fingers here when they project into the lateral ventricles. The corpus callosum, as we can see here, is frequently involved. Okay, and at autopsy, here we can again see lots of periventricular areas of demyelination. And if we do an MRI of the spine, again we see little patches like this of demyelination. Here's a little demyelinated lesion right there. As we'll see, this looks a lot different than the MRI of the spine in someone with neuromyelitis optica. Now, we don't usually need to do a lumbar puncture in multiple sclerosis. If the clinical history fits, the MRI fits, then we make our diagnosis. But if there's a questionable diagnosis, there are atypical features, then we'll do a lumbar puncture. And this is helpful because oligoclonal bands are seen in 80 to 85% of patients. So this can help to either support the diagnosis or to go against the diagnosis. Occasionally we'll do a test called a visual evoked response test, where we'll have a patient look at a checkerboard pattern on a computer monitor, and by putting an electrode back here, we can see how long it takes to get through the optic nerve, optic radiations, heavily myelinated pathways. And so this is usually slow in patients that have multiple sclerosis. All right, so big picture, during an acute relapse, we use high-dose steroids, methylprednisolone. And this would be really only for relapses that are significant. So you wouldn't do this for some mild sensory loss or something like that. But if we've got optic neuritis or weakness, then we'll use IV steroids. So the mechanism here is it decreases inflammation by reducing the polymorphonuclear leukocyte migration, and also can reduce some swelling by decreasing capillary permeability. So this helps patients to turn around. It really is not proven to make a difference, though, in the long run, most likely. So giving steroids doesn't seem to help patients a year later, but it does help to shorten the duration of the attack. Now, in terms of disease-modifying therapy, the older therapies are interferons and Glatiramer acetate. I would say boards still tend to ask about the older therapies, even though these are less effective than newer therapies that have come along. And so we have the interferons. You probably don't need to know the different types of interferons by name. But the idea here with the interferons is that it essentially makes the T cells less likely to gain access to the central nervous system and cause damage. And probably that is through reducing expression of these VLA4 proteins here on the T cells. And so that makes them a little more sticky and they can't get in as easily. So side effects of interferons, rather nonspecific, mainly just pain at the site where patients do the injection. It is worthwhile knowing that some patients can develop these neutralizing antibodies against the interferons. So if you have a patient that's been doing well for a long time and then they just stop or begin to have relapses, then we can check for neutralizing antibodies, and if they have them, we need to move on to another therapy. All right, Glatiramer acetate. I don't think you need to know the mechanism of this one because it isn't really well known. It appears to act both outside the central nervous system and as well as in the brain. Okay, but this is a daily subcutaneous injection, very well tolerated, except a very small minority of patients can have an acute flushing, chest pain, palpitations, feels like a panic attack. It's really intense, but it's an extremely safe medication. All right, so big picture is these medications reduce relapses by about 30%. Now, dimethyl fumarate has become an extremely popular medication for multiple sclerosis. It's an oral medication. It's been around now for 7 years. Very safe, well tolerated. Flushing is the most common side effect, but that's usually not a big deal. It can cause leukopenia, so we measure blood counts every few months or so just to monitor for that. But it's a great therapy. Natalizumab is an extremely effective medication. This is an infusion that patients come in for every 4 weeks. And look at this, reduces relapses somewhere between 67 and 90%. So natalizumab, I think I would know the mechanism. So here we've formed these monoclonal antibodies against the VLA4 receptors on T cells. So a similar kind of idea here, making these T cells less likely to get in across the blood-brain barrier. So biggest thing to know about natalizumab is it can cause progressive multifocal leukoencephalopathy, which is a horrible condition. All right, so we do need to check someone for a JC antibody prior to initiating therapy with this, and we need to go on and monitor periodically for a JC antibody. Fingolimod is an oral medication, and it seems to prevent T cells from escaping lymph nodes. And so there are 3 unique side effects with this medication. First is we can have activation of the herpes virus, and so we need to check for that, ask if someone's had chickenpox before and if they're vaccinated. So that's very important because this can be quite severe. We also need to do a baseline electrocardiogram because of the potential for causing cardiac arrhythmias, and it's recommended that patients see ophthalmology first because it can cause macular edema. They need to follow with ophthalmology periodically on this medication. All right, so it's an effective medication, but you can see obviously more significant side effects than with dimethyl fumarate. Teriflunomide seems to act by blocking pyrimidine synthesis, so this reduces proliferation of both T and B cells. This is one that we would want to avoid in anyone that has liver issues because it can cause elevation of liver enzymes. And then probably this one is too new to be asked on boards. The big thing about this is it's very effective for relapsing remitting. So like natalizumab, very effective, 70 to 80%. So that's significant. But the big thing here is it's approved for primary progressive multiple sclerosis, that more severe form that men get. So this is a B cell depleter, and our contraindication for using this would be in patients who have active hepatitis B. So the big picture is we have our lower, less efficacious medications, the interferons, Glatiramer acetate. Probably would put teriflunomide in this category. Medium, dimethyl fumarate here is the popular one, probably in this category because it's so well tolerated. And then the very effective Natalizumab, I didn't mention this one because it's too new, and Ocrelizumab are very effective, but again, potentially some side effects here that could be more significant. So Glatiramer seems to be the safest, but again, the feeling is, boy, we really want to prevent as many relapses as possible, and so that's why it seems to me I see a lot of neurologists starting out with dimethyl fumarate. So it's kind of a first-line, all-purpose for relapsing remitting multiple sclerosis. Certainly, if we have a really active disease, then we just go right to Natalizumab as long as someone is JC antibody negative. Okay, and remember, for primary progressive MS, we now have a new option, which is quite encouraging. Now, neuromyelitis optica can be confused for multiple sclerosis. Older terms is Devic's disease, which we try not to use anymore. And so this involves mainly optic nerves and spinal cord. And in fact, the brain is relatively normal in most cases, or you don't see too much in the brain. Patients that have NMO have more severe attacks that can even cause respiratory failure. Okay, and that is because when they have an attack, oftentimes it's not just little patchy areas of the spinal cord like multiple sclerosis, but when we do an MRI of the cervical spine, we see these longitudinally extensive necrotic lesions. And so there's so much destruction there that, again, that's why respiratory failure can even occur during an attack. So unlike MS, we don't get oligoclonal bands. NMO is even more likely than multiple sclerosis to occur in women. And we've got a specific antibody, the NMO antibody or the aquaporin 4 antibody. And so we can make a positive diagnosis here if we've thought about it. Okay, so all the medications I mentioned for multiple sclerosis are not helpful for NMO. And so typically we're going to use immunosuppressants like rituximab, which is a B-cell depleter. So here's a patient with NMO, and we can see the brain, a couple little spots, not too impressive, but look at the cervical spine. Okay, very significant there. So again, someone with the presentation is an optic neuritis, often a more severe optic neuritis, maybe that doesn't recover that well, and then a very significant cervical spinal cord demyelination, then you've got your diagnosis most likely. Now, ADEM, or acute disseminated encephalomyelitis, is another demyelinating disorder that is a once-in-your-life kind of a thing, a monophasic illness, not very common in adults, so we'd see this more often in children or young adults, and this usually follows an infection by a few weeks, like 3 or 4 weeks later. That would be kind of a typical time frame. But then once it hits, it's very severe. So patients have rapid progression. They're confused because of very significant bilateral subcortical demyelination and lots of focal signs and symptoms. So you involve motor and sensory and visual pathways. So patients are having weakness, sensory loss, visual changes, and so on. And so the white matter is mainly involved, and once patients get through the illness, and usually you're going to give them high-dose steroids during the attack, if you can get them through that, then they recover pretty well. Okay, at pathology, we see perivenular foci of demyelination, swelling, and so here's an MRI in someone with ADEM, and so again, you could think, well, this looks like multiple sclerosis, which it does. We've got lots of central nervous system areas of demyelination, but it's a single dramatic episode. And so typically we'll do a lumbar puncture in these patients. We check them for certain antibodies, which I think is probably more than you need to know at this stage in training. Now, a variant of this that is more severe is known as acute hemorrhagic leukoencephalitis. And so it's a lot like ADEM, but now we see all these areas of hemorrhage. So we have small vessel necrosis and demyelination with these hemorrhagic areas, and so this does not have as good a prognosis. Now, the leukodystrophies are the classic example of a dysmyelinating disorder. So again, we don't properly form myelin. And so classically what we see here is, you can see there's lots of demyelination going on here, but we have sparing of these so-called U fibers that are out here near the cortex. So these subcortical U fibers are preserved typically in a leukodystrophy as a distinguishing feature. Now, metachromatic leukodystrophy is due to an abnormality of aryl sulfatase A activity, and so this presents in infants. It's a horrible condition that usually results in death within a few years. And so at pathology, we see just widespread loss of myelin and also these sulfatides that accumulate. And that is known as metachromasia. Globoid leukodystrophy is very similar. Infants, rapid progression, but now the deficiency is of galactoserosidase, beta-galactosidase. And so this is called globoid leukodystrophy because of these nucleated globoid cells. Okay, and then finally we have the adrenoleukodystrophies. So this is X-linked, so it occurs in boys and men, and it's due to mutation of the ABCD1 gene. So we can now do a genetics test for this. And the other thing we can test for, if we think about it, is very long-chain fatty acids, because these accumulate in the adrenoleukodystrophies. And these are destructive to myelin in the central nervous system and also to the adrenal cortex. So the presentation can even be with adrenal failure, which can have a lot of different things, but maybe one thing that might stand out in a vignette is hyperpigmented skin related to adrenal cortex failure. So the phenotype in adrenoleukodystrophies is really broad. If it presents in kids, boys, it tends to be much more severe, bad prognosis. The presentation we see in adults is known as adrenomyeloneuropathy, and as the name indicates there, myelo, the spinal cord is involved. So these are usually men kind of between the ages of 20 and 40 that present with a progressive spastic weakness. Now, if we do an MRI scan, whichever phenotype we're dealing with here, kids or older individuals, we should always think of adrenoleukodystrophy if we see mainly parietal occipital areas of demyelination. So that's quite suggestive. Here is a coronal section through the occipital horns of the lateral ventricles, and we can see just really a lot of dysmyelination, I should say, back here in this area. And next time we'll talk about Parkinson's disease.